Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown.
This is the story of clinical ethics. Dr. Travis Brown, I sent you a confession yesterday that I have a head cold, to give you an option to pull out today or to continue. I don't like delaying our recordings, so was that an ethical decision that I made to put at risk my love for you to be able to say yes or no?
No, look, it is. It was a sacrifice, and doing right or wrong is always a challenge these days, isn't it? What to do is right, and that's why we're discussing clinical ethics. And this is a challenging area for doctors. In fact, it's a challenging area for healthcare professionals, and it's an issue that we've been dealing with for thousands of years. Surprisingly enough, even going back to Hippocrates, looking at the right and wrongs, the ethics, morality, behaviour. This is something that even is written in the Hippocratic Oath.
I swear by Apollo the physician, and Aesculapius, and Hygeia, and Panacea, and all the gods and goddesses, that according to my ability and judgment, I will keep this oath and this stipulation, to reckon him who taught me this art equally dear to me as my parents, to share my substance with him, and relieve his necessities if required, to look upon his offspring in the same footing as my own brothers, and to teach them this art, if they shall wish to learn it, without fee or stipulation, and that by precept, lecture, and every other mode of instruction, I will impart a knowledge of the art to my own sons and those of my teachers, and to disciples bound by a stipulation and oath according to the law of medicine, but to none others. I will follow that system of regimen which, according to my ability and judgment, I consider for the benefit of my patients, and abstain from whatever is deleterious and mischievous. I will give no deadly medicine to anyone if asked, nor suggest any such counsel. And in like manner, I will not give to a woman a pessary to produce abortion. With purity and with holiness, I will pass my life and practice my art. I will not cut persons labouring under the stone, but will leave this to be done by men who are practitioners of this work. Into whatever houses I enter, I will go into them for the benefit of the sick, and will abstain from every voluntary act of mischief and corruption, and further from the seduction of females or males, of free men and slaves. Whatever, in connection with my professional practice or not, in connection with it, I see or hear in the life of men, which ought not to be spoken of abroad, I will not divulge, as reckoning that all such should be kept secret. While I continue to keep this oath unviolated, may it be granted to me to enjoy life and the practice of the art, respected by all men in all times. But should I trespass and violate this oath, may the reverse be my lot.
Now, when we look at what he actually said, sometimes we cherry pick these days as to what parts we agree with and disagree with. And that's important, because even though it's been a discussion happening for thousands of years, Hippocrates was one of those ones that I'm not going to do this, I will do this, we shouldn't. It even talks about, the Hippocratic Oath talks about abortion, it talks about care for patients, not having relationships with patients, I'm not going to do this surgery because it should be left to train. So this is part of his ethics or his behaviour that he wrote down, and it survives to this day. And so Aristotle, who learnt from Hippocrates, there is time between them, but Hippocrates was pretty much the father of medicine, and Aristotle's there. But Aristotle took a little bit of a different perspective on ethics, and he was looking at moral behaviour and things like virtue ethics. So a good physician should be a virtuous person. And so a virtuous person will choose the right moral behaviour. So if you are good, you're going to do good. And so this was where he believed in prudence and practical wisdom, temperance, justice, compassion. But if you taught someone to be a good person, they will have good behaviour, good outcomes, good choices for their patients.
Did they teach you that in medical school? Was there a big section on this?
There was a section of this, and it depends on which school you go to. As to we had a law/ethics professor who was also a doctor, and this was his area, and it was actually quite large where I went to. Talking to other doctors, it was, here, read this book, which we will discuss in a moment, and it just depends on the university as to how much ethics or legal topic was involved. And so, again, this is looking at challenging decisions for doctors. So, weighing up individual circumstances, using experience and judgment. And this is, again, Aristotle comes back, one size doesn't fit all. And so we now have like a very similar scenario as to what they were dealing with 2000s. But then you add in modern technology. So you add in things like what we can treat, the diseases, the interventions we have is just so far beyond anything that probably you could have imagined even just a few hundred years ago. The type of people talk about, in uterine surgery type things of children who haven't been born yet. And it boggles the mind.
Hippocrates would not have even conceived, so to speak, of that.
And that's the challenge that we have. And again, operating on someone who hasn't been born, or again, it is just one of those things that you turn to these bioethicists. And so we even have someone like Albert Schweitzer who stated,
ethics is nothing other than reverence for life.
And I actually don't agree with that.
Oh.
No, because I think it's more than that. And this is where is it just respect for life? Is it quantity versus quality? Can someone can live another 10 years, but in a difficult scenario? And this is why there's quality versus quantity. So
doesn't the word life bundle that smuggle?
I don't know how specific he went on that. And that's the whole point is, does someone have the right to end their own life? And this is that the right thing to do? And someone who's terminally ill, who will not get better, who is in constant pain. And this is where modern medicine comes. And when we look at modern medical ethics, it pretty much comes down to a textbook that was written in the 1970s, Tom Beauchamp and James Childress, also known as Jim. They were in the 1960s, and they were actually doing religious studies. So they're not doctors. And they did the religious studies. Tom went on to do philosophy at Johns Hopkins University. Jim continued on at Yale and did a doctorate in religious studies. And there's two people who probably should get far more credit than they do these days, is Andre Helgers and Leroy Walters. Now, these are two people who got Tom and Jim and employed them to actually say, look, we need to look at ethics. Now, Andre Helgers was the director of the Kennedy Institute. He was a professor in obstetrics and gynecology, and Leroy Walters was the director of bioethics at the Kennedy Institute. And they got Tom and Jim to come and teach a course of bioethics at Georgetown University. So something that hadn't happened before. And they ended up creating the first course called Intensive Bioethics. This was 6 lectures, and it was for scientists, for doctors, nurses, public policy experts, and journalists to come in and discuss ethical problems. And so this was things like people refusing beneficial treatment. And so if a competent patient comes in and refuses life-saving treatment, okay, well, that's understandable if they understand all the implications. Well, what happens if the patient's irrational or has impaired mental capacity, or the family members disagree with what's going on? And then other issues like withholding or withdrawing treatment. And so we're talking about things like ICU. Is there a difference? Now, ethics people say, well, there is no difference between witholding and withdrawal symptoms, but emotionally it feels like there's something different there.
Are you going to give us the answers to these questions at the end?
No, this is the challenge with ethics, and this is why each scenario will be different. And this is the thing. When you talk about people assessing withdrawing, withholding treatment, you're talking about, what's dialysis? Is that life-saving? And what is intubation? Is that active? And this is where, what happens if someone has no chance of survival? Do you intervene in those areas? We're talking about, again, lectures. These are still relevant. Like, this was 60 years ago, about things about researching on vulnerable populations. So you're trying to do we just had COVID, did vulnerable populations testing vaccines on patients who don't have a choice or do. What is death? So when does someone die? Brain death. You can keep organs going. Abortion, which always comes up. Truth-telling. Is it always important for a doctor to tell the truth, even if it would be potentially detrimental to a patient or to their family or vice versa? And there has been scenarios I've encountered where family members didn't want a diagnosis told to their dying relative, their parent or something, because they thought it was going to be a negatively impact their life. And so what they ended up working out, Tom and Jim, they looked at pretty much two main theories. So there was deontology, which is right and wrong rules that you base on, and then you get the utilitarianism, so the consequentialism, where you're looking at it's the ends justifies the means.
The greatest happiness for the greatest number.
And this is one of those ones where they actually looked at all of these issues, and they started building this foundation. And this foundation now, we've got textbooks. It's called The Principles of Bioethics. And they actually wrote about their experience from these lectures as to why they were going to put this book together.
Our approach has been labelled principalism by critics and a four principles approach by supporters. In biomedical ethics, we do not always appeal directly to moral principles or to derivative rules. We appeal to them primarily in deliberation and justification in novel situations, for example, involving a new technology, in uncertain or ambiguous circumstances, and in outright moral conflicts. We defend what we refer to as a framework of four broad moral principles: respect for autonomy, non-maleficence, beneficence, and justice. We also defend several derivative rules, including rules of veracity, confidentiality, privacy, and fidelity, as an approach to professional ethics. We do not suppose that our principles and rules exhaust the common morality. We argue only that our framework captures major moral considerations that are essential starting points for biomedical ethics.
Again, this is still looking at what role does ethics play? And it's not law, it's actually saying what is the right thing to do here. Now, the law comes into consideration, but sometimes the law actually almost gives to the doctors what the right thing is to do. And if it's a considered choice, it's one of those things that can be very challenging, and there's lots of opinions. But again, it's looking at ethics as in everything we do, healthcare professionals, how do they conduct themselves? What are discussions, the choices that are available? And again, this is really coming down to trying to do what is right.
Dr. Melanie Jansen is a paediatric intensive care specialist and clinical ethicist who practices medicine on Turrbal and Niagara Land in Meanjin, Brisbane. Her clinical interests are in cardiac intensive care and ECMO, retrieval and the management of severe trauma. She has a Master of Arts in Philosophy and completed a Churchill Fellowship in Clinical Ethics and Medical Humanities in 2017. She's a PhD candidate at the University of Queensland, developing a pedagogy for complex ethical decision-making in critical care. She's also a published poet. Her debut poetry collection, All That Could Be Lost, was published by Five Islands Press earlier this year. That's 2026. Melanie is our guest on This Medical Life podcast. Welcome.
Thank you for having me.
Melanie, what role does clinical ethics play in medicine today?
Well, I think all clinicians do clinical ethics every day because every decision that we make in medicine has an ethical element to it. And most of the time, those decisions are uncontroversial. It's reasonably clear what the best thing to do for the patient is. They have capacity. They can discuss it with you, and off you go. I think sometimes, though, it's not easy. It's not clear, especially when you start getting, I think ethical complexity often, not always, accompanies clinical complexity where there's uncertainty about what to do, or if you have things that you're weighing up in a particular case that are really difficult to work out what's the right thing to do. So I think where a clinical ethics service can be really helpful is when, in terms of the case consultation, is when you get a really difficult case that as a clinician you've thought through and done all the usual things and you're still having trouble thinking what is actually the right thing to do here. You can then go to the clinical ethics service and they can help you work that through. And what I think, and clinical ethics services operate differently in different places and in different countries, in different hospitals in the same country. The approach that I think is most helpful is if you treat it as a mechanism for clinicians to get support in decision making, and you can apply what we call a fair process to the decision, so that all of the reasoning is sort of transparent, is comprehensive, and everybody can feel a bit of moral peace about what the outcome is of that decision, because we never know if it's going to turn out how we want. We have to make all these decisions in good faith. But even if it doesn't turn out as you hoped, you can look back and say, look, we did this in as robust a way as possible, and we can feel, I think the word peace is quite a good one to use in that setting.
Looking at ethics, is this really just about conflict resolution?
No, although, in practical terms, often conflict does arise in difficult ethical situations, especially, so there can be conflict between a patient and a doctor, or a patient's family and the medical team. There can also be disagreement sort of between different specialties. In the hospital system, we often, especially in my clinical practice, there's nobody, I manage nobody by myself, they're always owned by another specialty. And in the tertiary hospital, usually 2 or 3 or 4 and sometimes 7 or 8, depending on how complex they are. So there's all sorts of conflict that can arise over different things. And I think part of the reason conflict can happen a bit more when people are worried about ethics is because the ethics really gets to the heart of what really matters to people. And when there's some neuroscience research behind this, that when you feel sort of ethically conflicted about something, you really get quite a bit of limbic hijack, because they're really deeply held emotional reactions that we get to these things about our core beliefs. So there is some conflict resolution involved in clinical ethics consultation, but it's a tool to get to the heart of the problem. It's not your whole job. So I did mediation training in the past, and some of the skills that I learned in that do help in my ethics consultation, but there's much more to an ethics consultation than simply a mediation.
How does an ethics committee differ then from a legal committee?
So because a legal committee, or any legal opinion that you get, they are there to help you practice within the law. And so we all have to practice within the law. But for example, a hospital legal person, or any your legal person that you might consult about something. Say, for example, if you're trying to make a decision about what's in the best interests of someone who doesn't have capacity, whether they're an adult who's lost capacity or a child who doesn't have it yet. So the law will say for children, for example, that the medical decision needs to be made in a child's best interests. And that's it. That's where it stops. So it's up to us to figure out what their best interests are. And that is the ethical question, because hardly anybody ever, in paediatric practice, for example, everybody is always trying to do what's in the child's best interest. It's just that they differ in their opinion on what will actually serve the best interests, or indeed what the interests even are sometimes. So that is the ethical work. I sort of look at it that the law gives you boundaries within which you need to practice. And the way that lawyers think about things can be very helpful in the process. And in the clinical ethics service where I work, we always have a legal person on the response group to a particular case, just to be part of the discussion. So so I think the ethics is in, and I've often worked very closely with legal service, and they really like it because they feel that the ethics really helps to, in a practical clinical sense, operationalise the principles that the law is trying to keep you inside of.
Is it too simple to say that the legal people there look at the letter of the law and the ethicists are in looking more at the spirit of the law, or is that too simple a rubric?
I think it's probably a bit too simple, but there is some insight to be gained from it. So, for example, the law will often say that you need to do things in line with good medical practice. So then the doctors need to decide what good medical practice is, and that there's actually ethical questions inside of that. And they're the bits that the lawyers won't help you with. They go, well, you tell us if it's good medical practice, and then we'll tell you whether you need to go to the tribunal or not.
Yes.
Looking at the Clinical Ethics Committee, can you tell us how that works?
So it works differently in different places, and it's actually one of the criticisms of clinical ethics as a profession or practice, that it's quite variable. Now, I don't think that's necessarily a weakness, because I think different models of service will work better in different settings. But for example, early in the days of clinical ethics committees, which was in the Western world, probably in the sort of late 70s, early 80s, ethics committees were often convened kind of ad hoc for difficult cases, and usually when a hospital or an organisation foresaw some legal issues. And so you would either have what we call this kind of wise old man model, where there'll be some senior, clinician in the hospital that's, quite erudite and probably has read a bit about ethics, and people go, oh, let's see what that guy thinks. And there's nothing wrong with consulting senior colleagues and things, and that model probably worked quite well a lot of the time. And then you would have this sort of committee that would be convened ad hoc. And that one of the common things might be if somebody was requesting a late termination of pregnancy, for example, which isn't strictly illegal, but it's something that people can have, and I'm talking about some time ago. I know a lot of the legislation has changed around that in the last years, but so you would convene a committee, and often I think it sort of looked a bit like a human research ethics committee. They'd say, oh, well, we'll get a psychiatrist, and we'll get somebody with a religious background, and we'll get somebody from law and a couple of senior clinicians, and we'll all sit around and decide whether we think the hospital will go ahead with whatever it is they're discussing. And then quite rightly, there were some cases that were like, well, who are you guys, and why do we have to do what you think? So what kind of ethical authority do these committees really have is another question. Fast forward to now, and over the last couple of decades in particular, in, say, the UK and Australia, and a lot of places in Europe operate reasonably similarly, that they will have like a multidisciplinary committee, and some will operate in the way that they'll say, well, the ethics committee meets once a month, get your difficult cases in, we'll deliberate, and give you some advice or some reflections or some possible ways forward. A lot of those differed with, were the clinicians involved or the families involved in the room when you deliberated at all? There was no real, different places operated in different ways. I personally don't like that model, because I think there's all this moral information or ethical information that you don't necessarily get from a case summary that's written to you. And I think the real value comes from being able to discuss with the clinical team what they're struggling with, and sort of go back and forth. And as you discuss, you find that the clinicians will clarify their thoughts as you ask them questions, challenge certain things, devil's advocate certain things, ask them to really spell out their reasoning for why or why not they think, something should be done or not. So you can have these committees there which you submit a case to, they deliberate and give you some advice, and the type of advice they give is quite different. They might rarely would they say, we think you should do X. They'll usually just give some kind of general analysis to give the clinicians something to think about. And then most of the clinical ethics services in Australia, we run what we call a peer support model, where you'll have a similar committee. So in the places I've worked, you'll draw from a group of people who are usually other clinicians who've done some training through the ethics service to play this role in responding to consultations. And we, as I mentioned, always have a legal representative as well. And then we have a structured discussion format that we go through. So we get all the clinical information, then we ask what the kind of narrative information, what matters to all the people involved, what the emotional experience has been for the family, patient, clinician. And then we'll go through an analysis phase and say, well, what are the possible ways forward here? What principles are we trying to uphold? To whom do we have obligations and how strong are they? And then we really step out and make it very clear that why the decision was made. And so that has, so we call that sort of procedural justice. And I can go into that in a bit more detail, but the basic idea of it is that you need to have a transparent process, that you need to be accountable for the reasons that you give for why you're moving forward. And then when you're transparent like that, you can then look back over previous cases and you might start to get insight into substantial moral principles that might be coming through frequently and get some insight into how we make decisions over time. So there's an element of social learning involved. So when I do an ethics consultation, that's what I do. I bring a group, we work with the clinical team through this structured decision-making process, and then we together with the team make a plan for how it's going to go forward, and then all those notes get added to the medical record. I sometimes get asked, when I've presented about clinical ethics and the services I've worked in overseas, and people go, do you keep data on how often the clinicians take your advice? And I say, well, no, because they kind of always take my advice, because I'm not giving them advice per se. I may give them little bits of advice throughout to say, look, I think it would be hard to justify this when usually you do this. So I might evaluate some of their reasoning, but in the end, we together come up with a plan, and that, and then the clinical team can feel sort of supported in these really difficult decisions, that they've made as good of a plan as they can.
Reading about the clinical ethics committees, the cases fall into level 1, level 2. Can you give us some examples of what would fit into category 1 and category 2, or levels?
Yeah, so that was levels that that a lot of the services in Australia use. I'm not sure it's and each service will define what that means for them. But generally, how I divide level 1 and level 2 is level 1 might be, you get a call from a team going, hey, we've got this complex case, we're having an MDT meeting about it. Do you think you could come along and kind of be part of the discussion? So I would call that a level 1, where I turn up to a meeting that's already organised by a team, and I'm just one of the people in the room. And sometimes, as you get through the MDT process, people get on the same page about things, and the things people were a bit ethically worried about kind of melt away as you do that. And in that case, I might, just be sort of part of the discussion, and then the team ends up making a plan, and it's not too complex, and it's documented that I'm there, the clinical team documented as they normally do. Sometimes you'll go to an MDT like that and you realise that there's really intractable snarl of ethical problems that is going to that we really need to dig into. And so then we'll say, look, we probably need to have what we call a full deliberation or level 2 response, where then I bring my ethics team from that group that are in the response pool. So we have our quorum, all the clinical team again come, and then I chair the meeting and we work through, as I mentioned before. And then I document it, make a summary of the decision making, and then the clinical team will, everyone checks the notes, and then we put it into the medical record. So it's really a matter of, so the ethics service sort of takes control in a full deliberation and really steps through all the ethical issues in great detail. Whereas in the first one, you're just a member of a team adding a bit of, your thoughts and knowledge to that particular situation. So the full deliberation obviously much more labour intensive and for more complex cases.
Do you have any example or topics that clinical ethics committees have to deal with?
Yeah, so it's a huge there's a huge variety, especially where I work now is a whole of life hospital, actually all the way from neonates through to geriatrics and everything in between. So end of life comes up a lot for, say, for example, deciding whether to move from an active curative intent of treatment to redirect to palliation. And there may be people that disagree, whether it's the family or different clinicians in the team, disagree with whether that's the right thing to do in that particular situation. There may be conflict between surrogate decision makers and the clinical team about what's in a patient's best interests and what surgery or intensive care therapies or procedures might be reasonable to do. We've had some referrals about sort of somewhat like experimental therapy for rare things, and whether it's the right thing to go forward with. So I think, it comes down, there's a lot of stuff around end of life. There's the experimental therapy issue comes up a reasonable amount. In the Children's Hospital and actually in the whole of life hospitals as well, you might get issues with the developing autonomy of adolescents. So adolescents might disagree with their parents and agree with the doctors or any version of that in the triangle of people that look after children and adolescents. So there's some examples of what might come up.
We're certainly looking at it prospectively. Someone saying, look, I'm not sure, is this what the right thing to do is. Do you ever look at cases retrospectively? I mean, it's a bit hard because, a clinician would look back and say, did I do the right thing here? And then be the uncomfortable conversation of saying no or yes. But did they ever look retrospectively?
Often, actually. And so the clinical ethics, people often think about the case consultations as the key work of the clinical ethics committee, and it's very important work. But actually the bulk of my work in my clinical ethics role is in education and workshops, and that includes retrospective case discussion. And I find that when departments ask me to come to do education, it's often because they've had a difficult case that they're all wondering about, or they might have cases along the same theme and they go, oh, this keeps coming up and we're just not quite sure whether we're doing the right thing with it. Yes, we do retrospective case debriefing. And what I have found interesting in that part of the work is often when I would go to talk about a case with a team, and I have noticed this, for how long have I been doing ethics now? So 15 years, that you would come and do a case discussion. And I would often find that by the end of the hour that you're with them, that the whole thing has taken on the quality of a bit of a debrief, and people saying, oh, I had this terrible case and it kept me up at night for this and it was kind of like this, and people start sharing things they've found really difficult. And I think that's great, but I did start to feel like I was doing some well-being debriefing sort of by accident, and I think particularly say 15 years ago, there weren't very many spaces in the medical system for people to have those discussions. So you'd have an ethics education and it was a space where you start talking about what's important to people, and all this, reflection and would pop out. And what I'm really enjoying at the moment is I do quite a bit of work in partnership with our wellbeing service at the hospital. So in Queensland, particularly, we've got some fairly recent legislation about protecting staff from the psychosocial hazards of work. So there's been a little bit more attention paid to wellbeing. And so there's a senior social worker that runs the wellbeing service at the Gold Coast. So I went to him and I said, look, sometimes when I do these education sessions, I feel like quite a bit of wellbeing stuff comes up. We were asked to do some sessions with the intensive care nurses, for example, about some difficulties that they were having. And so we went together, and he said, well, I really like this because he said sometimes when I'm doing wellbeing sessions, a lot of what's bothering people is the ethical stuff. And I don't feel that I am necessarily qualified to really dig deeply into the ethical theory behind things. So we've found it really great to do it together. So I think that's been a really interesting part of my work, which speaks to that retrospective case discussion. And then people can really, like any other retrospective case discussion that you might do at morbidity and mortality, the goal is to sort of learn from and see what we could do better next time, but also in supporting people in what they're doing now. And I think because we know that moral distress and injury is one of the big drivers of burnout in healthcare professionals, which we all know is all over the literature, is bad, bad, bad. So I think if this is something that we can do that helps that's a really worthwhile use of the ethics service as well.
We're about to pause to take a breath because we're going to come back and focus our attention on how clinical ethics help doctors day to day. But I want to get a one-sentence answer from you. You'd be familiar with the fictional character House. If you were the clinical ethicist in House's hospital, how would you manage him?
I would invite him to be part of the committee, tell him that I would love for him to come along to the training that we do, and I would manage him that way because I think he's got a lot to offer and he needs to be in a space where people can challenge him and channel all the good things that he does more effectively.
We continue our discussion with Dr. Melanie Jansen as we turn our attention now towards the best way clinical ethics can help doctors in day-to-day clinical practice. Melanie, are there any studies or any evidence that ethics committees are actually beneficial?
There is some evidence. It is one of those things that I think it's difficult to get that sort of linear evidence that we like in medicine. You know, you have this problem, we do a randomized thing with this and it gets better. Because by its nature, it's a web of complexity. And if you pull on one thread a bit and one thread here, it probably does make it all better, but it's kind of hard to catch it in numbers. So there are some, quite old now and mostly in the US setting, there's some evidence that says that organisations that put an ethics service in place then had less critical incidents and less litigation. There are some randomised controlled trials done in ICU in the States where the intensive care unit randomised people to early ethics consultation or just ethics consultation whenever people decided. And they found that they decreased length of stay in ICU without increasing mortality. So essentially, people who were going to die anyway had less, we got there quicker. You know, I mean, that's one interesting sort of linear study that's been able to be done. And then there's quite a bit of emerging evidence in the wellbeing space, including, so I actually did a retrospective data analysis of our ethics service at the Children's Hospital several years ago after we'd had the first 2 years of activity. And we had taken surveys from the clinicians that had used the service every time we did a consultation. And one of the key findings from that survey was that people who had referred a case, had been involved in the ethics consultation process, felt less moral distress afterward than they did before. And there's some, a few other studies have shown similar things. Again, a lot of these studies are small. The response rates to the surveys may not be high, but I think there's a pretty decent signal around the wellbeing stuff in the literature at the moment. And in particular, there's a signal showing that doctors that feel more confident in ethical decision-making, and usually that correlates with them having done some educational course, they feel less moral distress in their day-to-day practice.
Are there any guidelines or standards about clinical ethics available for doctors?
You know, we have our codes of conduct and all that sort of thing that have ethical elements in them. In terms of resources to help with clinical ethics decision-making, you mean, or how services work?
Well, really about how, if they're wanting to actually reading about, or is there any guidance for them to read about, maybe this decision is how I'm going to get to where I need to go? Is there any guidance in those areas?
There are some different ethical guidelines for different therapies. So, for example, ELSO, the International ECMO organisation, they have ethical guidelines about how you should make decisions about ECMO, for example. And I'm sure other therapies have that as well. Like I'm sure different dialysis groups have things like that, etc. There was a plethora of guidelines put out around COVID, around rationing. So if anybody ever wants to think about how to ration, there's plenty of those around these days. There's not a lot of specific guidance, and a lot of the criticism that I've heard anecdotally when you have sort of ethics guidelines is people go, but they're just like a bit motherhoody. Like, we really want help with the nitty-gritty, how to actually get in there and make these decisions. And I think it's hard to make, a flowchart type thing that might be helpful, because it's every single case is a bit different, and the nuances of it change how you will weigh different elements. So there's certainly ethical guidelines and decision frameworks to help with specific things. There's an experimental therapy one from Great Ormond Street Children's Hospital that I've used quite a lot as a way to step through decisions about experimental therapy, for example. So there are different things around, but they're usually quite general, or they're about a very particular therapy.
A lot of people will be familiar with ethics committees in hospitals. What about doctors who are not in hospitals? You can refer, or is there some way for general practitioners to actually get ethical advice outside the hospital?
Not that I know of, except through accessing ethic service in a hospital that their patient might be in. And again, that's difficult because there actually are hardly any clinical ethics services in Australia. It was last surveyed in the early 2000s, and it said that there was about 10% of hospitals in Australia had a clinical ethics service. And I actually don't think that's probably changed much, although as far as I'm aware, we don't have a new survey. But I know, for example, in Queensland, there are 3 hospitals in the whole state that have clinical ethics service, and one that's just recently gotten funding and are going to set one up. And it's about the same in New South Wales. Interestingly, all of the children's hospitals in Australia and New Zealand have clinical ethics services, but almost none of the adult hospitals. But in direct answer to your question about general practitioners or people outside the hospital system, I know at the children's hospital, for example, if you had a complex patient, the GP would sometimes be contacted and invited to come to the meetings. Obviously, that's very difficult for lots of GPs with the way they need to practice in their time. But I think if you had a patient that had to go into a hospital that had a clinical ethics service, you could certainly access that clinical ethics service. But as far as I know, there's nothing, similar to how you have, you can ring up your medical defence organisation. There's nothing that I know of for ethics like that. I think it's a direction we certainly need to go in. And in Queensland at the moment, we are in the early phases of setting up a clinical ethics network for the state. And I would plan that would be something that any healthcare professional in the state could access.
I'm going to throw one quick wildcard question again, because that's what I'm here for. Again, a sentence or two on this one, even though it's probably a little bit unfair. For pleasure, at the moment, I'm reading a book by Alain de Botton on applied philosophy, and I'm loving it. Do you think we would need less people like you if in our society we all had more of an appetite for philosophical thinking?
Yes.
Wow.
So, but I think there's still a lot of value. So I agree. And I say, a lot of what I do in a clinical ethics consultation is philosophical reasoning, Socratic questioning, and getting people to make explicit their arguments for things. And a lot of the skills that I teach the people that are coming onto the clinical ethics service to be one of the volunteers that will help with cases, it's essentially a crash course in philosophical reasoning. But I still think there is value in having an organisational mechanism for a clinician to say, this is a really difficult case. And often when you've been a clinician from the start of a case and you've been walking through it as it unfolds in real time, you see it in a certain way, and sometimes stepping back and going through this robust process and applying those procedural justice principles to the process, I think will never not be a useful thing to have, even if we're all very good at philosophical reasoning.
Last question. Do you have any final thoughts, Melanie, or even just advice for doctors about clinical ethics?
I think that we definitely shouldn't think of it as something that only ethicists do, and that it's something that we should take on as a CPD activity. And there's quite a bit around that you can access some really good organisations. I'll email you some links for people to access. And I think we should take it on. We should recognise that ethical reasoning and thinking is a skill that we can hone in the same way that we hone all the other skills that we use as doctors.
Lovely. Dr. Melanie Jansen, we will put those links in our show notes. Mm-hmm. Thank you very much for being part of This Medical Life.
Thank you for having me. It's been a pleasure.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is at Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.